2, 1. Please start, sir. We are live.
A very good evening, all distinguished delegates and today's eminent faculty, Dr. Johny Kannampilly, sir. I would like to give a brief introduction about CLEARTalk. CLEARTalk is one more facet of Unite Against Dyslipidemia. And the recent development in the management of dyslipidemia is Bemdac acid and Clear Outcomes trial, which was presented in American College of Cardiology 2023 in the month of March. And to give us a brief about and one of the best faculty. So without
there is some lag in your internet.
Yes, sir. So now it's audible?
Yeah, now it's fine.
Satish, some lag is there, sir.
So I would like to introduce Dr. Johny Kannampilly, sir. He's a senior consultant, Metnonia Diabetes Research Institute, Lakeshore Hospital. He has many awards, recognitions, membership of different international and national forums, ADA, IDF. He's a founder member of National Diabetic Food Society. There are many affiliations, awards to his credit, but this is a small slide from my side. I can fit in some of his affiliations, recognitions, and rewards. Without wasting much of our time, I would like to hand over to this session to Dr. Johny Kannampilly, sir. So, thank you. Over to you, sir.
Yeah, thank you very much. We are in the verge of a real time bomb where the diabetes and coronary artery disease are the ticking bombs in front of us, leading to devastating complications, especially with the current lifestyle which our younger generation is going through. Younger and younger patients are coming with coronary artery disease, diabetes, obesity, dyslipidemia, and all the other comorbidities like peripheral vascular disease, etc., leading to various devastating complications. And now we have a new kid in the block in the treatment armamentarium to tackle this problem in the future for our patients. So bemdac acid is the new kid in the block, and we are going to look into the latest one of the trials, that's the Clear Outcome trial, which we would discuss and see how this molecule is going to benefit in our treatments. Next slide. Can we go to the next slide?
Satish,
Visible, sir?
Yeah. So LDL, we all know that LDL is the biggest target we have to look into in reducing this vascular events in our patients. And various studies have clearly shown that the LDL, the lower the better. And we have now newer guidelines which tells us lesser the better, and the relative risk reduction of at least 38 milligram reduction of LDL itself brings down 23% relative risk reduction. Of course, we have other molecules like PCSK inhibitors, but they are very expensive and it is injectable. So in our current armamentarium, we have this new molecule which can help us to reduce the LDL in a greater way. Next slide. So this is again just to show you that the LDL reduction greater the LDL reduction, the longer the duration, the percentage of risk reduction is higher. You can see from 11% risk reduction to 36% risk reduction as the patient on the trial for more than 6 years. Next slide. Next. So in the management of dyslipidemia, we know that the first line is statins. But do all statin users achieve the LDL goals as per the present guidelines? And the second question is, how do we achieve that LDL target after maximally tolerated dose of statin? Next slide. Just go back. Yeah. So do all statin users achieve LDL? Yeah, just go next. Yeah, fine. So we have the Lipid Association of India, which brought down a risk stratification of CVD. So we have low risk, moderate risk, high risk, very high risk, and extremely risk patients in Indian group of patients. So next slide. Next. Yeah. Here you can see that by the Lipid Association of India's guidelines, you know, they recommend less than 30 milligram of LDL. Of course, low risk is 100, below 100, and very high risk is below 50. An extremely high risk group, less than 30. So next slide. So if you look at the EASC guidelines from 2016 to 2019 guidelines, you can see the change in the guidelines. For from 115 in the moderate risk, they brought it down to 100. And from 100 for high risk, they brought it down to 70. And very high risk from 70, they brought it down to 55. And in our Indian patients, we have yet another target that is very high risk. They brought it down even below 30. Next slide. It is said that in newborn children, the LDL is below 30. Newborn children's, if you take the lipid panel, you can see that their LDL is around below 30. Based on revised EASC guidelines, how many patients do have controlled LDL? Next slide. So here we just want to show you the Da Vinci study. It's an observational cross-sectional study from 18 countries where there was about 5,800 patients. That's around 6,000. Next slide. And what they found was around 27.6 patients were eligible patients who are receiving high intensity statins. And in that, they found that 30% patients achieved the lipid goals with high intensity statins. So only 30% could reach that with high intensity statins. So there is still a big chunk of group who don't reach the targets. Again, you can see that very high risk patients also, 37% patients were eligible for receiving high risk intensity statins, and out of which only 22% patients achieved the lipid goals with high intensity statins. So in these patients, we definitely need a risk. So tolerated dose. Next slide. Maximum tolerated dose of statin. Next slide. We can go forward. Hello. Yeah. So this was data which was published in Cardiovascular Disease by Banch et al. The progress in cardiovascular disease in 2023 in ASCD CVD patients. Check the baseline LDL, and they found that in ACVD patients like acute coronary syndrome, stroke, and PAD, if you give high intensity statins, only 50% achieve the targets. And if you add a high intensity statin with an acetamide, you can take it up to 65%. Now, if you make it high intensity statin with a benfoic acid, you can take it up to around 70. So it is better than adding an acetamide. Now, if you add both that high density statin and acetamide and benfoic acid, you can reach as high as 75% risk reduction. Of course, 85% is with high intensity statin, acetamide, and PSK inhibitors. Well, if you look into the hypercholesterolemia also, familial hypercholesterolemia, you can see that fixed dose high intensity statin with acetamide brings around 65% reduction, benfoic acid around 70%, and all three, the high intensity statin, benfoic acid, and acetamide, brings it down to 75%. And in such group, if you add PSK inhibitor, you can achieve up to 85% risk reduction. And if you want to still achieve higher control, if you add benfoic acid, then it can even go up to 85%. They also found in this data that around 40% of the patients were statin intolerant. In patients, statin intolerant patients when they gave just benfoic acid and acetamide, because they were not tolerating any kind of statins, they gave this benfoic acid and acetamide, and they got a 40% reduction. But if you want to go further to reduce, then we may have to use in such patient PSK inhibitors. Next slide. Well, again, this is just to show you that this is an actually high intensity statin, how low adherence, which leads to higher MACE. So higher the statin dose, there is a high percentage of people who don't tolerate that dose, like myalgia and various other things. And once they don't tolerate, then there is a higher chance of MACE. Next slide. So that is where we have this new molecule like benfoic acid, an ATP citrate lyase inhibitor, a first-in-class LDL lowering drug. Next slide. So it is now approved in many countries, including USA, including European Union, etc. Just go back. So reduced uncontrolled LDL with maximum tolerated statin dose, mixed lipidemia, familial hypercholesterolemia, high risk of ACVD patients, all these group of patients, we can give benfoic acid. And apart from that, we can also use it in patients who are statin intolerant or contraindicated. So 180 milligram orally with or without food is the dosage. Next slide. So if you look at the journey of this molecule of benfoic acid, you can see that 2020 US FDA approved it, and European Union approved it again in March 2020, and 22 it was recommended by the Lipid Association of India, AACC, in October 2022, and March the CVOT trial came out, March 2023, a very recent outcome trial, which we are going to discuss in the next couple of slides. That's the CLEAR outcome trial. And to April to 2003, other lipid groups have also been recommending it. Next slide. Yeah. So benfoic acid, actually, the important thing which we need to understand from this complicated diagram is that there is no action on the skeletal muscle with this molecule. So the benfoic acid does not cause any kind of myalgia or any other symptoms. Next slide. So the management of patients receiving benfoic acid therapy, they found that there's no dosage adjustment required for renal or hepatic impairments. And only problem is we have to monitor the uric acid levels. They could have 1% to 2% patients can have an increase in uric acid. And patients who have already a history of gout, then you have to definitely keep an eye on it. Again, patients who are more than 60 years of age taking corticosteroids, fluoroquinolones, with renal failure and history of tendon ruptures, these are the areas where we should exclude this molecule. And patients who are on high dose statins, like simvastatin more than 20 milligram and pravastatin more than 40 milligram, this may not be the ideal combination. Maybe you can switch to another statin or lower the dose of that statin. Pregnant ladies, breastfeeding, all this molecule has to be not used. Next slide. So this is what we are very important to know. The recent trial, that is a clear outcome trial, which came in the New England Journal of Medicine, and it was presented in the AACC 2023. So it's a late-breaking clinical trial, and you can see cholesterol lowering by benfoic acid. So we look into the trial. Next slide. So here you will have benzoic. The study was about, the primary endpoint was the effect of benfoic acid versus placebo on 4 components of MACE: CV death, non-fatal MI, non-fatal stroke, coronary revascularization, etc. Well, around 13,000 patients were on the trial for 40 months. The follow-up was there. Next slide. So we know that statin intolerance is seen in 15% of the patients. And in such patients, this molecule definitely was added. And the CV outcomes were assessed. Next slide. So the key primary and secondary endpoints. Primary endpoint was the non-fatal MI, non-fatal stroke, coronary revascularization, cardiovascular death. So next slide. So here are the clear outcomes, and this is basically the demographic data. It was matched. The benfoic acid arm versus placebo arm was matched in terms of age and other parameters. Next slide. And you can see from the outcome results that there was a 4-point MACE, there was a 13% risk reduction. The 3-point MACE, about 15% reduction, and fatal and non-fatal MI of 23% risk reduction, and coronary revascularization of 19% risk reduction. Next slide. So the effect of trial regimen on CV events among statin intolerant patients, treatment with benfoic acid was associated with lower risk of 13% 3-point MACE and 14%, and MI about 23%, and coronary revascularization about 19%. Next slide. We also can see from this trial there was about 21% reduction of LDL compared to the placebo arm, and about the HCRP reduction was about 22%. Next slide. Now, if you look at the safety outcomes, safety analysis, both the arms, benfoic acid and placebo arms, were almost similar. There was no myalgia or no other problems. But only thing is, a small group of patients, there was an increase in uric acid. So that has to be kept in mind. Next slide. So the conclusion of the CLEAR outcome study, benfoic acid becomes the first ACL inhibitor and the first oral non-statin to demonstrate statistically the significant reduction in the 4-point MACE events in patients with who are at high risk for CVD with documented statin intolerance and elevated LDL cholesterols. So to conclude, benfoic acid is an effective alternative for statin intolerant patients. Well tolerated, CV and HCRP reductions, primary and secondary endpoint reductions, an effective approach to reduce the major cardiovascular events in statin intolerant patients. Next slide. Or as an add-on. Next slide. So thank you very much for your patient listening. I think we can open the forum for discussion.
Thank you so much, sir, for such a comprehensive presentation. There are few questions which are on my slide. I'd just like to refresh this box and ask few questions. My patient is having diabetes and my patient is also having hypertension. How much LDL cholesterol goal should I aim for this patient? What is your recommendation? That is the question.
Patient only has diabetes and
there's no much information it has been supplied here, sir.
So I normally try to keep my LDLs below 17 medium risk patients. This is actually a medium to high risk patients. So I would definitely try to keep the LDL below 70. But if already patient has a coronary event or on stenting or any other thing, then I would like to keep it below 50.
Yes. So there's the next question is, there's in diabetes patient, how safe bempedoic acid is? Because there were trials which were saying that there's no new onset of diabetes which was observed, but statins do have this problem. So what is your take on as diabetes?
Well, I think even though there are small studies which shows that statin has got a incidence, but then the benefit of statins is definitely proven with various other trials. So as a first line, I'll still stick with statins. And if the LDL is not coming below, then I would add a benfoic acid or an acetamiprid, whichever deems fit for that patient pocket. And definitely if the patient is intolerant and to statin, then also we can consider a benfoic acid and acetamiprid combination. Now from these trials, we have clearly got indication that benfoic acid has got CVOT benefits. So that is an additional point worth to keep in mind, that apart from the statins reduction, once you add a benfoic acid, your risk reduction, you're still bringing down. So the risk reduction which I showed in the CLEAR trial was mainly on statin intolerant patient. So a statin plus a benfoic acid, and if needed in very high risk patients, an acetamiprid also. Definitely if you can keep in Indian patients below 30, you're going to achieve a great reduction in the risk.
Thank you so much, sir. The next question is about how long you have in your day-to-day practice given bempedoic acid, and how much LDL cholesterol you have observed in your personal experience?
Well, my experience was very limited. It's just a new molecule. I've just started using it and yet to see the review of these patients. So I'm not in a position to answer to that questions. Maybe in the next talk or something, we can look at the data and tell you.
That's great. There was another question is about patients who are, you said that according to European Society of Cardiology 2019 guideline, patient has to be kept under 55 milligram per deciliter. Is there any neurological complication one can see at this level?
No. These are all were the concerns in the earlier stage. I had a discussion with some of the world authorities in lipids in one of the meetings which I attended. And they were saying that there was a doubt whether suicidal risk and things like that. But now that these are all not very confirmatory, or there's no other risk in like that. And as I said, in young individuals like newborns, actually the LDL is only 30 or below. So that itself shows that we have to keep it below 70, or I would prefer most of our patients may have some amount of coronary artery disease or something like that. Then I would try to keep it below 50. And if severely high-risk patients, maybe 30 in our Indian patients.
Thank you, sir. Indeed, it was a pleasure having you on board on this evening. Any final concluding remarks would you like to say before we conclude?
Yeah, I think only final concluding remark is the molecule is good, the evidence is good, the clear data is excellent. So use it, but at the back of your mind, keep the uric acid in mind. In the first month, make sure you check it 1 or 2 times. Make sure that if the uric acid is going up, maybe you have to withhold. And patients who are having a uric acid between 6 to 7, they may not be the right candidate to start it. Below 6, check the uric acid levels. It's below 6, then you can add a benfoic acid. And it's not just we have clearly shown the benefit with the CV outcome results, with the clear data that the risk reduction, apart from the statin, there is another 23% risk reduction. So that's a great thing. So we are able to bring down the risk with these newer molecules, and I think that's the way forward. And the biggest killer of a diabetic patient is CV events. And I think we should make sure that we keep the LDL of our patients at a lower level, as low as needed by the target recommendations. Thank you.
Thank you, sir. Over to Suresh for final remarks and a vote of thanks. Thank you.
Yeah, sir. So, sir, once again, sir, I, Suresh Kumar, RBM Citus Medica, is honored and privileged to propose the vote of thanks to our eminent doctor, Dr. Johny Kannampilly. Sir has always been in the forefront for helping us in organize such knowledge sharing platform. And today also, sir has helped us in organizing such a very good talk on CLEARTalk on bemdac acid. Thank you very much, sir. I express my sincere thanks to all the delegates. Yes, sir, for joining this knowledge sharing platform and making the session very interactive. I express my thanks to all my superiors and to Mr. Satish for rendering all the support for organizing this program. And I express my thanks to all my colleagues and especially to the tech team also for coordinating this program very well. Sir, once again, very sincere thanks to Johny, sir, and all the delegates. And I request each and everybody to help us organize such knowledge sharing platform in the coming days also, sir. Thank you very much.
Thank you, and good night to all. Thank you.
Good night, sir. Good night, sir.
Thank